Well, good evening from the Eastern and Central time zones of America, where the presenters are, and good day to those that are able to join us from around the world. So this is part of the ongoing AO North America Hand online series, three cases, the Fireside series, and this, as you know, the topic will be radial head and neck fractures. This idea came about by Marco Rizzo, who's the chair of the Hand Education Committee from Mayo. And just so you know, Marco this year was nominated and received the Hand Educator of the Year award. So this is a great honor for Marco. Group tonight, I'll be moderating. I'm Jeff Lawton from the University of Michigan, Rob Wysocki from Rush, our SAGE, Dr. Jupiter, emeritus from Harvard, and our hand therapist, Keely Elwood, from Mayo. And this series of talks is really helped by the presence of therapy. I will say that the award that Marco got for the Hand Educator of the Year is named after Dr. Jupiter. So Dr. Jupiter has taught us much of what we know about hand, wrist, forearm, and elbow care for patients. So we're very pleased that he's able to join us tonight. So all of our conflicts have been mitigated, as you see here. So many of you know, but for those who are new to us, AO is an independent nonprofit surgical society dedicated to improving care of patients with musculoskeletal injuries. We are going to try to not talk about specific plates and screws and implants, but concepts and education. Equipment used is for demonstration and teaching. And again, the learning experience can be enhanced by it, but it's not how to use a specific plate or screw. For those of you who are interested in CME credit, as you know, this is a series. At the end of the series of webinars, there will be a link sent to you at the conclusion, and you can claim those credits. So just a little bit on Zoom etiquette, as people are still filling in a little bit. All of your microphones and cameras have been muted. However, we do want to hear from you. Please send in your questions through the Q&A function. We will look at those and, based on time, present them to our panelists, maybe answer directly. And the chat box we are going to use for us to internally communicate to hopefully make this a seamless presentation for you. So I am your moderator, and then I'll move into a case, which is a fairly straightforward case. We'll get to talk about some evaluation, some biomechanics and management. Obviously, we're spending most of the time. Dr. Jupiter is going to take us through his reflections on how he does it and lessons learned. And then Rob Wysocki is going to talk with us about complications. And even though this is set up for three cases, Rob has a few complications. And as with many things, we can often learn more from our complications than when things went well. And again, Keely is going to talk about therapy, not just specific for radial head and radial neck fractures, but I've asked her to talk about some elbow therapy principles in general for everyone's benefit. So our objectives at the end of this, we'd like our learners to be able to identify radiographic indications for surgical procedures being discussed, identify and understand the clinical criteria required for indication of these procedures, define the appropriate surgical anatomy and steps in execution, recognize possible pitfalls and develop strategies to avoid them, and then review pertinent literature and outcomes. So just to let everyone know, there's a couple of upcoming webinars on scaphoid non-union and failed carpal and cubital tunnel syndrome. And then a few others on extensor tendon imbalance with Jerry Huang, slack wrist with Peter Stern, Monteggia fractures with Daphne Bingesser, and TFCC injuries and DRUJ instability with David Roosh. In terms of in-person education, our very own Rob Wysocki is chairing hand and wrist regional course in Chicago, and myself and Chuck Cassidy are chairing the advanced wrist and elbow course in Palm Beach Gardens, Florida. And we've got a very special guest star, Jesse Jupiter, is going to join us because it's sort of a home game for him He lives in the neighborhood, so we're going to get a little cameo from Dr. Jupiter. If there's something you want to go back to or something that one of your colleagues wants to see, this will be up on our YouTube channel, and we're going to be on OrthoTV online as always. So we'll go into my case and some principles of evaluation management and some thoughts about the radial head and radial neck, disclosures that aren't relevant. So again, our objectives are to evaluate radial head and neck fractures, comprehend the importance of the anatomy, both the injury and the surgical exposures, explain relevant treatment, reduction, fixation principles, replacement principles, and then evaluate radial head and neck ORIF versus replacement as surgical management options. So anyone that's ever seen a patient from the ER, this is sort of a typical young person, has a fallen and outstretched hand. And again, you know about the fat pad sign, and what those represent is a normal fatty structure in the olecranon and radial head coronoid fossae that get displaced by the effusion, and it shows that subtle sign. So radial head injuries are relatively common. Anyone that works on a college campus or an urban center, these e-scooters and e-bikes are sort of ubiquitous, and they're a great generator for these. But radial head, radial neck fractures are about 20% of all elbow trauma. And as you might anticipate, a fallen and outstretched and typically pronated forearm forces the radial head into the capitellum. So as you know, the wrist, the distal radius receives about 80% of the load, and whether the interosseous membrane is intact, radial head is intact, determines how that gets then transmitted at the elbow. So various sectioning studies have demonstrated the importance of the interosseous membrane transferring the load from the radius to the ulna. And at the elbow, it's more like 60-40 than the 80-20 at the wrist. And this is largely due to the presence of an intact radial head and the central band of the interosseous membrane. So the osseous stability, as you know, is due to the radiocapitellar joint. It's responsible for force transmission in all positions, valgus stability, and axial stability, maximal in extension and pronation. The role of the radial head, and we'll talk about the role of radial head resection, but radial head resists valgus force. It's actually mechanically less important than the MCL. However, if you have a complex injury like a terrible triad and the MCL is insufficient, then the radial head becomes more important. And we'll talk about implications for trauma and radial head resection. So radial head fractures have been classified a number of ways. Most common that we talk about is the Mason classification. Type 1 non-displaced, type 2 displaced involving 30% of the head or 30 degrees of angulation, and then type 3 comminuted. Johnston added comminuted and added associated with a dislocation. And there's really three main surgical options for treating a radial head fracture: resection, replacement, and ORIF. I would invite you in a trauma situation to consider two main options, that being ORIF by various means that we'll discuss, and replacement. So a Mason 2 represents the head neck segment is in some component of the head neck segment is intact, but the head is split. That gives you a framework to build onto it with either headless screws or subchondral traditional screws. And this has been looked at mechanically and radiographically, and we know about it clinically. So here's a typical displaced radial head fracture. You see the capitellum to the right and the split radial head. So anatomic reduction, stable internal fixation. As you see here, you can see the subchondral screw. This is recessed below the articular surface, as you see here and here in rotation. So a nice restoration. So a Mason 3, more comminution, where there's no head neck continuity. And in this situation, if we can fix it, we plate it or replace it. We'll talk about that because it's important that, again, in the setting of trauma, the radial head does have a role, and we do want to think about replacing it to prevent valgus instability, axial instability of the forearm, posterior ulnar humeral instability. So we always want to think about fixing or replacing, and how we make that decision is actually one of the contributions of Dr. Jupiter. So 20 plus years ago, this article looked at the comminution, and what they found is that with less than 3 fragments, there was better than 90% satisfactory results. However, with greater than 3 fragments, there was greater than 90% unsatisfactory results. So that 3 fragments has become sort of a line in the sand. And that's based on Dr. Jupiter's experience. So again, we want to think about fixing some and replacing some. Remember, if we're thinking about fixing, these hyaline cartilage covers about 2/3 of the radial head. The anterolateral third is void of articular cartilage, but it lacks strong subchondral bone, and this is the most common place where a fracture occurs. And this non-articulating portion of the radial head is known as the safe zone. So as we look at this cartoon in rotation, we think about the safe zone relative to a neutral forearm, and it's about a 90 to 110 degree arc. And if you think about having a plate, that's where in full pronation and full supination, a plate does not engage the PRUJ. So just a special thought about terrible triads. So when it's more than just the radial head fracture, but there's also instability, as you see here. So comminuted radial head fracture, and you can see the ulnar trochlear subluxation and radiocapitellar subluxation. So ORIF, this is an older slide with older plates, but as you see here, you can get a nice result. We have newer locking plates, as you see here, and there's a number of different configurations. These are nice and low profile, and actually some of them allow you to even close the annular ligament over the plate. So here you see typical comminuted fracture. Here you see the plate with the forearm neutral and that safe zone. And here you see a typical radiographic result in a terrible triad. You can see all the evidence of ligamentous injury. So impediments to stable fixation. As we know, the radial head is, this is from my friend Peter Evans, who carved a radial head out of tofu, because sometimes that's how the radial head just gets sort of smashed. So the impediments to radial head fixation and stable fixation are small fragments, a lot of cancellous bone, more so than cortical bone, articular cartilage predominates, and we have the PRUJ to think about. So again, lots of this colors are decision making. So again, with a comminuted radial head fracture and instability, as you see here, something that you deem unreconstructible, we want to think about replacing. So we're encouraging folks not to just resect it and replace it if you don't think fixing it is reasonable. Just a word about replacement. It's important in the operating room to get this view, and you can see the lateral aspect of the cornoid, and you want to make sure that the radial head is a little bit distal to that, and slightly undersized. So this is a typical case. Again, these e-scooters are sort of ubiquitous here. A college student who had a fall and has this fracture that on this view doesn't look so bad. And then you see the central comminution and depression. So how are we going to get there? 2 main approaches. The lateral approach of Coker, as you see here, which is a broad approach that takes down the lateral collateral ligament, as you see here. And then at the end, we repair it. Versus Kaplan's approach, which starts the same proximally, but then stays anterior to the lateral collateral ligament, as you see here. And that's what I did in his case. So here you see, it's his right arm. You can see the capitellum, you can see the radial head and the plate, and that lateral collateral ligament would be in this area. And this is what it looks like after. And then you get him moving early, and he's got good flexion extension and good forearm rotation. So I want to thank you for your attention. I have a few questions that I will pose later for Dr. Jupiter. Questions in my mind and questions that we all want to hear, but I will transition and let Dr. Jupiter enlighten us. Thanks, Jesse.
Okay, that was great. Let me approach the same consideration. Repair or replace is really the basis of what we should be talking about versus resection. I think I'll highlight again a little bit more about the kinesiology, the relationship of the radial head to forearm and upper extremity function is probably more critical than it gets its due. Therefore, it's probably a really good idea to try to preserve the radial head if you can. It's a good rationale for internal fixation. And there are some reasons why we would not want to jump to arthroplasty. So if you look at it from a three-dimensional perspective, in the coronal plane, the radial head works with the medial collateral ligament, as you heard, preventing valgus deformity. But also in the sagittal plane, it works with both the capitellum and lateral soft tissues to prevent posterior dislocation of the elbow. When you flex and extend your arm, your forearm wants to go proximally. So obviously this is a buttress against that. And we know about in the axial plane that the radial head helps prevent proximal migration, especially if there's soft tissue injury to the forearm. If you look at prostheses that exist today and look at the normal anatomy of the radial head, they're not quite the same. And the radial head is really an ellipse, and it's angled slightly off the axis of the bone itself. And it does move when you're pronating and supinating. So it's really a dynamic articulation that we'd like to preserve. The second thing is the blood supply to the radial head. If you look at this, is a nice study. It's a Spaterholtz injection type study that was done at Mayo, but the major vessel goes in at the neck, the radial head, and sometimes the head itself gets blood supply in the lower third or distal third from that vessel or two vessels as seen here, but it's not always consistent, and the articular or proximal 2/3 is really getting its nourishment from the synovial fluid. So if you have a fracture that extends to or through the neck, or you're doing operative exposure with those plates and screws, you have to keep in mind that there's a potential for devascularization of the repaired radial head. And as was mentioned, I started seeing this in some of the cases that were doing very well, but they came back, sequential follow-up x-rays showed the fracture really had never healed. And when we removed the radial head, it was really necrotic bone and cartilage. And that's where we came up with this idea that if you have three or more fragments, and particularly in B, if it extends into or through the neck, you have about a 25% chance that it'll go on to non-union. At the same token, in a situation like this, a patient did very well, had an unstable injury. So the radial head served as a buttress there. But follow-up, over 4 or 5 months, it was clear that it never healed. And by removing it, she had already stabilized the soft tissues about her elbow. And her function remained very good with a slight valgus instability. Here's another case from that study with a similar situation and remained very functional. So keep that in mind, but that doesn't necessarily mean you shouldn't try, and it doesn't necessarily mean that the healed radial head or not one that doesn't heal doesn't provide a biological spacer, but it's probably a good idea to let your patient know that may need a second operation. Prosthetics come in different types, bipolar, monoblock, they're too stiff. And as was mentioned, if you have it too large, you're probably likely to get some problems with the capitellum, as illustrated in this case report, showing sequentially problems with erosion of the capitellum. Graham King has done a lot of study in this, and really a good idea if you're going to contemplate this is x-ray the opposite elbow, get a good idea of the excised fragment of the radial head as to the height and diameter, and then choose the narrowest diameter. Because the radial head is elliptical, choose the narrowest diameter to consider the size of the head. And as mentioned, lie flush or 1 millimeter proximal to the lateral edge of the coronoid. Instead of putting a larger radial head prosthesis to help stability, consider reconstruction of the ligaments. So excise the neck, the radial head to the neck, and cheat on the smaller side as possible. Better to leave it shorter than to be proud. And there's a number of papers that are coming out looking at patients who have had implants and having to undergo removal. This is one paper that had 70% rate of removal. So it does have some potential problem. Obviously, it's better if you could preserve your own radial head. It's a lateral stabilizer. It's a force couple with the lateral collateral ligaments. It prevents posterior lateral instability, and it prevents proximal migration of the forearm. And importantly, it's anatomically correct. There's no bone, no joint like your own. So a situation like this may be worthwhile trying to put these pieces together, even though it, in quote, has 3 pieces. I think these 3 pieces, if put together, 75% by that study would not go on to non-union. You can almost have a sense of what type of injury it is from the type of fracture. A pure bony injury, a shearing type injury, may be one that has joint incongruity. Certainly, if you have the radial head split in 2 pieces, both anterior and posterior, you have to worry about an axial load that occurred and treat that as a so-called Essex Lopresti. And then rotational instability is very important. And I'll mention this and mention it again. If you have a radial head or neck fracture that on presentation, it's posterior to the lateral column of the humerus, that's a sine qua non of elbow instability. I think you can fix many of these with screws alone, as was mentioned. And I think with the smaller screws they've improved the length of them, and you can bury the head just underneath the subchondral articular surface. I think that these offer a better option in trying to piece these pieces together. You heard about Coker's, and actually the posterolateral approach is not really Coker's, but the Kaplan approach that was described. This is the posterolateral approach. But the Kaplan approach is actually, if you looked at Coker's paper, it looks more like this as well. Whatever you call it, it's important to stay above the equator of the radial head, if you can, because that limits the risk of the lateral soft tissue, keeping that intact. What about the posterior nerve? Well, in most patients of normal size, it's going to be about 3.5 to 4 centimeters. distal to the joint. So it's a pretty distal to get involved with your surgery. And simple fractures can be done through any of these approaches without concern about creating instability. But here's the situation I'm telling you about, that this patient comes in, may sometimes have reduced itself, the elbow, as was done in the emergency room, but having that x-ray with the radial head and neck displaced posteriorly is a tip-off that there's been an instability. And this was repaired, but kept in a temporary fixator for 2 weeks. Here's another example of that, where you see the lateral soft tissue complex is pulled off the lateral epicondyle, is so-called bald epicondyle. And repair of the radial head is very effective. And even with these screws, you can go into the neck, as shown here as well. And function, hopefully, will be restored pretty well. So the type 3 fractures that may or may not present the big problems, particularly if they extend into the neck and or displace neck fractures. I think that it may be difficult to put these pieces together, but don't bail out until you've tried, because it may well be that these small screws may help. And with impaction, remember, you have a little defect under the fragment, so a little piece of bone graft, perhaps from the distal radius, would be helpful. And here are these small headed screws. This is a 4-part fracture with 4 major fractures and extending into the neck. And here's a post-op CT and follow-up. Even with traditional screws, this could be dealt with effectively because the fracture goes into the neck considerably. And this patient also had a good function. Another example where your head and neck are displaced posteriorly, repaired. Soft tissues are put back to the lateral column, and the screws through the head and neck extending in that direction. Function. Another example done. So it looks like a blowgun with darts, but it's obviously strategically placed to the fragments and a functional outcome. And finally, a complex forearm fracture with radial head. This is sort of an anterior fracture dislocation and the functional outcome. And we looked at this with 23 patients with this screw fixation technique. 8 were associated with elbow dislocation and 2 terrible triad. And generally, the range of motion was restored to a functional level. The quick dash was very satisfactory. But that non-union still is an issue, even with a stable fixation, because of the blood supply, not really because of failure of fixation and some minor complications. So when do you go, and what's the problem with the plates? Something like this with a big instability pattern with very common fracture. I think the plates, my own personal opinion, are still too large. Yes, they offer locking, and yes, they're more strategically designed, but they're still quite large. But you can get smaller implants within the maxillofacial sets that companies make that can do the same job and yet be much lower profile. That's what's done in this particular case and a functional outcome. Here's another particular case where it's assembled on the table and put back. This is a little larger plate, and the coronoid was fixed as well. And if you look carefully, you'll see at the neck of the plate, it's broken, which may or may not represent instability, but it may represent a non-union. See that more clearly now. But again, it works as a biological spacer, and the function was good. It had to be removed, but she had functioned pretty well. Another example with a smaller plate in place. So I think we'll hear a little bit about complications. And like any elbow trauma, they can be particularly vexing to the patient and to us surgeons. Avascular necrosis is probably the reason why when you have a non-union, that's the reason, not because of unstable fixation per se. And I think internal fixation is becoming more and more appreciated, particularly with improved implants. And as with many elbow trauma, it can be technically demanding. So I'll turn it over to Rob now.
Thanks, Jess. That was great. A couple questions came up. So you sort of suggested, without saying, that you will sometimes push the envelope and fix more than 3 fractures.
Yes.
Is there anything that you look at in terms of the fracture pattern, the number of pieces, the displacement, that sort of clues you into fractures that are more or less likely to go on to AVN?
Right. If it extends substantially into the neck, and/or that radial head or neck has been displaced quite substantially posterior to the lateral column, there's a greater chance of that occurring. But bear in mind that even if it does occur, it may occur at 3 months, 4 months, where the radial head has served as a buttress to allow the soft tissues to heal.
And then there was a question that came up in terms of age. Do you have a minimum age for consideration for radial head replacement?
Well, that's always a problem. It comes up. Maybe that's best left for the people who deal with kids all the time. I think that better management of the soft tissues to provide stability. I would hate to put in metal implants in a child, but there's sometimes that if you have a real forearm instability, you may have to do that.
How about a 20-year-old? Does that give you as much pause, or is
No,
that
no,
okay?
it doesn't.
All right, excellent. Well, thank you. So next, Rob Wysocki from Rush is going to share some complications. And again, we appreciate the sharing of complications, because often we can learn more when things don't go as we planned than things go perfect. Thanks, Rob.
Sure. Hi, everyone. Thanks for joining us tonight. Again, I'm going to go through with as much time as allows, anywhere between 1 and a few cases, and just engage the faculty as a panel to see how they would make some of their management decisions moving forward for these cases. So first one, 30-year-old male trucker, 8 months after beginning non-operative treatment of a partial articular radial head fracture. So this is one of the low Masons that you heard Jeff talk about, a 1 versus 2, depending on if you call it displaced. Complains of activity-related pain of the lateral elbow, especially with weight bearing on the palm, and when he has to do forceful gripping in extension. He's not noticing any mechanical symptoms. His symptoms have been ongoing despite OT, an attempted cortisone injection into the joint. You can see tenderness on exam over the radiocapitellar joint and radial head. Mild limitation in elbow range of motion, probably about 10 to 15 degrees each direction. And supination and pronation reasonable. Supination a little bit more limited than what would be expected. No crepitation or instability. So I think the panel would probably agree these are relatively unimpressive radiographs. Starting this is a bit of a simple case to start with. I guess I would ask Jeff and Jesse, have you seen this scenario, and would you say you've seen it a lot, where we think the literature would suggest that a minimally displaced partial articular fracture should do just fine, but this relatively young trucker is having pain? How often do you see this scenario, and how do you tend to at least manage it early on?
Yeah, I mean, I agree. It appears concentric, and if you want to get a CT at this point, that would probably be what is most commonly done to see if you're just not appreciating some articular incongruity. And then I think your options are sort of let them ride versus depending on what you see on the CT. I mean, it might be something that would respond to an osteotomy versus a radial head replacement.
Yeah,
I would
thanks, Jeff. Jesse, go
CT.
ahead. Thanks.
Favor CT.
Yeah. So we did get a CT. I will say before opening up the CT, I'll say for me personally, I've been in practice now 16 years. I probably once a year see someone. It's almost always someone in this age range, 20s to 30s, relatively young, who looks like they should have a painless healed partial articular fracture at 8 months, 12 months. They can really be struggling with pain. And it's a tough thing because you look at it and the images aren't exactly nauseating, yet the person's unhappy with their elbow. No mechanical symptoms. It's a pure pain. And I think it's a little tough sometimes to talk them down off the ledge. Here's the CT. You'll see first on the left, we'll pan through some sagittal images. So we can see a partial articular. As is typical, it's primarily the anterior margin of the radial head which is involved, at least in a position of forearm pronation. As you start to fully supinate these folks, the fracture presents to you a little bit more, but it's mostly the anterior margin, including in supination. You'll see the coronal cuts here. Once again, it's painting the picture of roughly 40 to 50% partial articular fracture, looks like no more than 2 millimeters displacement. I really like these 3D CTs with the humerus subtracted. I think they're so good at giving you a gestalt of the size of the piece. Where is it? How impacted is it? Etc. So you can see, I mean, I think it's probably 2 or fewer millimeters displaced. It's less than 50%. I think one good thing to really look for and scrutinize on the sagittal CT is whether it looks like the capitellum's falling into the defect or not. Is the capitellum following it, which means that you almost have an uneven surface rubbing on the capitellum? Because if it's falling with the depressed fragment, you can imagine an uneven surface that could wear down cartilage. If the capitellum doesn't appear to be traveling with the depressed fragment, then it's more just the equivalent of a negative defect. It's almost like if you just had your car tire and you removed a central portion of the rubber of the car tire. It still should be pretty smooth on the road. It's just that you would have a decreased joint contact surface area, so theoretically wear down your cartilage somewhat faster. But it doesn't necessarily explain acute pain. So this guy clearly hasn't worn down substantial cartilage, we don't think. So Jeff or Jesse, have you been in a position, I guess, what are your thoughts now, management strategies for this situation? Anything further you've found could work non-surgically? And then you see remaining questions there. I'd kind of like your guys' thoughts on these question points.
I'm going to say, just as you were able to eliminate the distal humerus to get those perfect views, you probably would want to eliminate the radius and ulna to look at the capitellum on your CT to make sure that there's not a divot or some articular incongruity on the capitellum.
Yeah, so that's a good point, Jesse. And I imagine you guys have maybe seen these too. It's interesting to me when I fix partial articular fractures, how often there's a sizable cartilaginous small, it's hard to describe it. I mean, it's a little shell of cartilaginous tissue that's wedged into the fracture. It's kind of amazing that it happens mechanically. I don't understand the shear forces that actually wedge it into the fracture, but it can almost be tricky to excise. You get a small hemostat in, try to pull it out, and sometimes it can be a nauseatingly big piece that's been removed from the capitellum, and you sometimes wonder if that could be almost a piece of third body wear, kind of, if it's sticking out from the fracture. Have you guys seen that? Am I kind of describing that piece well? Because I think I've seen it a bunch of times.
I'd say the other point to always keep in mind is for a 20-some-odd-year-old to have a fracture of the radial head, you have to really think carefully that there's something else that occurred in the injury. It's just not common to have a radial head fracture isolated in a young person.
Rob, one other thing, you sort of mentioned on the CT that it didn't seem like the capitellum went with that depressed piece, but if you have fluoro in your office, you can set them up to get a true lateral of the elbow and then rotate the forearm and see if in a certain position corresponding to that, as you said, probably no more than 2 millimeter depressed 40% of the joint, if the capitellum is tending to sit in that, and that's allowing some subluxation, then that might be something that you might consider doing something more aggressively for, other than just sort of letting them know to watch it.
Yeah, that's a good point. Because remember, for the audience, how three-dimensional the relationship is at the radiocapitellar joint. So if you're holding the forearm held in a neutral position, usually this fragment is going to be straight anterior, or even a little bit medial to anterior. It doesn't really start to become very relevant until you go into full supination. And even in full supination, usually you're just starting to see that edge of the fracture. That's how you present it to yourself. So I think that the capitellum is most at risk of engaging that piece in full supination. And remember, one of his chief complaints was pain with gripping in full extension. So it almost brings up a picture of, is there some subclinical PLRI where he's a little loose, and when he goes into a position of supination and extension, that's when that piece comes into play, and maybe he is falling into it a little bit that wasn't seen on a CT scan in neutral rotation, for example. So yeah, Jeff, I agree.
That's my point, though, is to have a radial hip fracture at that age, you have to suspect the possibility of something else happening, a soft tissue injury.
Yeah. Can you guys think of anything else to offer him non-surgically?
I had arthroscopy.
Yeah, it's an interesting thought, right? To see if there is one of those little cartilage spikes that's kind of poking out of the radial head, some sort of plica that could explain it. It wasn't offered to him in this case, but nothing lost technically by trying. So if you guys were going to offer an osteotomy, would you have a preferred method of fixation in this case?
I think it would be screws. I mean, you could do, I haven't done one at 8 months, but I've certainly done it at, 8 weeks or 12 weeks. They usually seem to present a little bit earlier than that, but, sort of recreating the fracture and cheating down the neck a little bit to give yourself as big a piece as possible, then elevating it up, and then a couple of subchondral screws or headless compression screws, whatever you choose.
Yeah. Jesse, thoughts? Would you do the same?
Yeah. Yes.
Yeah, so that's what was done in this case. You can see it's a little bit of an opening wedge, which was treated with autograft. And at the time of the surgery, and this is actually a case from my partner Mark Cohen, but at the time of the case in supination, the capitellum did start to engage with that depressed piece. The joint wasn't frankly subluxating majorly, but you could see that it was starting to engage it and roll out a little bit more than you would expect into supination extension. So they did kind of tighten up the native ligament. So it did seem to make sense. You can even see, I think, on that image on the left side, and even a bit on the right, you almost get a little bit of a V sign posteriorly, like the radial head still wants to maybe sit slightly posterior in relation to the capitellum there. So there probably was a little bit of looseness, and it's maybe a little bit hard to know. It was part of that some degree of attritional stretching over the 8 months too. Like maybe initially the ligament was more stout, but over 8 months, as he just starts to fall in a little bit, it just keeps stretching because you've lost that anterior buttress. So it's allowed to wander a little bit more posteriorly, and it becomes almost somewhat attritional as well.
One of our audience members also brought up the opportunity to obtain a CT in his position of maximal discomfort, and that might accentuate that more so than plain film or fluoro.
Yeah, it's a good point. It would have been interesting to have a CT scan and maybe full extension, full supination, even have him kind of gripping at the same time. It would be interesting to see what that would look like. Pre-op, obviously, yeah. All right. If no other thoughts on this case from the faculty, let's go on to this one. This was him, by the way, at 3 months. He's now I just talked to my partner because this is my partner's case. He's about 5 months out of the procedure. Much improved elbow. He's actually workers' comp too. I think he even already went back to work full duty, notices a substantial improvement. So it was able to help him. This is a 34-year-old female who came in self-referred to me, clerical worker, 14 months out of surgical treatment of a right radial head fracture in an outside facility. This was, again, a partial articular injury. She complains of stiffness in forearm rotation. Symptoms are ongoing despite OT for 7 months and static progressive splinting. You can see her elbow range of motion, similar to the other patients, reasonable, probably lacking 10 to 15 degrees each way, but quite limited rotation, 30 and 50 sup pro compared to the other side. So clearly by far the most morbidity from the lack of supination. These were injury films. So again, we're talking a partial articular injury. I don't have a preoperative CT scan. But for Jeff or Jesse, briefly, based on your lectures, I think I know the answer to this question. But assuming you think this met surgical criteria, what would be your internal fixation of choice?
Either small headless compression screws or typical lag screws just buried beneath the articular cartilage, I think would serve well acutely.
Okay. Jesse, anything different?
No. But I would want a CT scan on present.
Okay. Yeah, so I would always get a CT scan on one of these that I'm kind of considering surgery for. So I guess number one, a follow-up question on your internal fixation, because you guys and Jesse especially showed mixed constructs. How do you decide about doing subchondral rafting screws parallel to the articular surface versus the angled screws towards the radial neck? What are your guys' preferences and how do you decide for this injury?
Probably involvement down the neck and then more of that tripod kind of construct.
Yeah, I agree.
Going down the neck. Jesse, if I could ask a question, I don't know if I'm allowed to ask a question sort of like the other end of the triangle, but if you get a CT and you see that what that represents is not sort of a third of the pie, but it's more the rim of the articular surface, does that shade your thoughts to fixation versus replacement?
No. I'd still try to do fixation.
Okay.
She's 34 years old. I also worry about axial load instability. I'd want to get in the OR, let's say, a stress test of her forearm, make sure she doesn't have Essex Lopresti or interosseous ligament injury.
And is that grasping the proximal radius with a lobster claw?
That or pushing up the flexed hand forward against the distal humerus.
Okay.
And Jeff, am I understanding you correctly then? If there was no extension down the radial neck, you favor oblique screws towards the neck?
If there were no extension down the neck, if it's solely a head fracture, then the orientation is largely transverse.
Parallel. Okay.
Parallel. Yeah.
Yeah. So I've kind of changed my philosophy on those a little bit personally. There's a couple of things I really like about the obliques, and I'll use them for pretty much all of these, even these ones that are more the simple articular variant. I still feel like the fixation is probably better when you're exiting out the neck. So instead of just rafting and what you guys commented on is very weak bone, kind of like the tofu bone, I like the fact that I'm getting cortical fixation on the far side. The other great thing is that it's okay for the screw to be long because it's exiting out extra-articular. So it really can be tough when you put those transverse ones in. You're sweating it, because it's a round structure that you're putting in. You're coming out a concave surface. So you think that you're not sticking out the far side into the PRUJ, but you got to supinate and pronate and try to make sure the threads aren't hanging out. You can really sweat that. And I think there's a risk of those screws going in too long because they're going into the joint versus exiting out at the neck. It doesn't have that risk. I guess there's that risk that the axis of fixation doesn't really fit the axis of the fracture itself or the plane of the fracture. But I haven't seen these compress and really displace themselves with the oblique screws. Jesse, I don't know what you favor for these types, but I've personally gone to the oblique screws out the neck for pretty much all of these rather than transversely oriented.
I guess I tried to emphasize that with my cases. The more oblique screws, yeah.
Yeah, okay. So that was not what this patient had. So this patient had ORIF with a radial head plate. And I know Jesse mentioned it briefly in his talk, talking about size of the plate. A lot of the manufacturers make plates that will go all the way around the head of the radius, around the rim, like a rim plate as is seen here, versus ones that almost cup it kind of from underneath for simpler fracture patterns. So this would be the more proximally oriented or more bulky of the plate options compared to what is out there. So I think a lot of us would agree this is probably much more fixation than was needed for this fracture type. So now we have the fracture's healed, probably healed acceptably. I don't see any screws that are in the joint, but we're dealing with a stiff elbow lacking a lot of supination with a bulky plate on. So Jeff or Jesse, I'm assuming you'd probably offer this person some sort of a hardware removal and address some tight soft tissues. Can you maybe just describe your strategy in this operation, assuming you agree she's indicated?
Yeah, I agree. So, plate removal and capsulectomy. So the numbers you said, her 35 and 40 of rotation, that was after this plate or that was before this plate?
At 14 months post-plating, she's lacking about 50 degrees
Gotcha.
supination and only about maybe 25 degrees pronation compared to the other side. Mostly supination loss.
Yeah. So again, this is the bulk of the plate could be doing it, but while you're there, capsulectomy and see if you can get her back some more motion.
Can you describe what you mean by capsulectomy for the audience? Like how do you do it? What do you release in what direction? How do you get it done?
Well, they probably already released the annular ligament because you can't have the annular ligament repaired with this. So it can be contracted to the plate, and it can be a tether, and that could be, as she's trying to rotate, it could be scarred down there. So incising what's left of the annular ligament, elevating it off, and taking the plate off, and then opening up the PRUJ.
So would you plan to go far enough medial to see the PRUJ when you say open up the PRUJ?
Yeah, so I would actually, whether you do this by Kaplan or Coker's, I sneak higher up the humerus and then look in from the front. So you're taking down the extensor, and then with a retractor, you can look in and you can actually look all the way over to the tip of the coronoid and the medial aspect of the coronoid. So you can see it really well from, quite honestly, an anterior view from lateral.
Okay, great. Thank you. Jesse, thoughts on this for your procedure?
Hey, I think maybe you could try to do it without taking down the lateral soft tissues and just go an interval, but you have to get to the posterior radiocapitellar joint and anterior radiocapitellar joint, and then look down at the radial ulnar joint from both ways. So it's a relatively extensile part of an elbow joint release. If you don't get satisfactory motion, don't forget about the distal radial ulnar joint, because I would still keep in my mind that this could have been an axial loading injury, and sometimes you may have stiffness all the way in the forearm down to the distal radial ulnar joint.
Thank you. And would you guys, as this plate starts to extend a bit distal, would you have any PIN concerns? Would you make any effort to try to dissect it out and visualize it, or no? Or how far distal would the fixation have to go before you would truly do that?
Certainly beyond 2.5 to 3 centimeters, you have to start worrying about it. So I would want to identify it, and especially as this person's already had surgery and you don't know what was done. For screws, as Jesse sort of said, no, but for plates, yes, I want to see and mobilize the PIN.
Thanks. And can you describe for the audience what interval you find the PIN in? How would you do it when you're doing this case?
I actually will go through the supinator, so anteriorly dissect and then go through the supinator. And quite honestly, as you're dissecting through the supinator, it's probably not the most beautiful of dissections, meaning that you're sort of having to violate the supinator to find the nerve.
Hey, Jesse, would you agree? Would you plan to probably find the PIN in this case?
But I would start looking at the radial nerve more proximal to the joint, and then follow it distally, so you have it under direct vision the whole way.
Okay. Yeah, I think I do agree with finding the PIN here. I think you'll feel a lot more calm doing the release for sure. I like to find it in that next anterior window. So find that kind of fleshy red substance of the ECRL, and then just try to tease that off of the combination of the white EDC aponeurosis and the ECRB that lies below. So you're almost coming in from above. And then you have that little almost like subfascia of the ECRL from above, that once you incise, you see the oblique fibers of the supinator, and then just go outside of the zone of previous surgery, find where the PIN is exiting the supinator distal, then probably get under or get over it with a right angle and release it from distal to proximal. But I would try to find it outside of the zone of injury, but you can usually do that just by jumping one more interval anteriorly. And the incision doesn't have to be a whole lot bigger. It wouldn't go much higher than like a lateral epicondylitis incision would be. So it would be a different working window than going through in a EDC split to try to do the release. So did the release here kind of as described. Something that was taught to me by Mark Cohen was the benefit of just pronating and supinating the forearm almost to your knife. So once you get the hardware out, you start releasing any soft tissue staying on bone, and you just keep pronating and supinating, and new elements of scar present themselves to you, and you just keep cutting them off both over the top and down the bottom. And then typically you'll have it freed up once you've done that. And that's in the several or so that I've done, I've found has been pretty effective. So again, it's you're rotating the forearm almost to meet your knife. And just keep freeing up as you manipulate. So you can see this was at 6 weeks was the last time she saw me for her elbow, but the supination, pronation, both looking better already. And she didn't follow up after that, although incidentally, I saw her 3 years later for her wrist, and I had forgotten I ever did anything for her elbow. Maybe she forgot. She didn't bring up her elbow, so I'm hoping that means that she's happy with it, but I guess who knows. But I'll probably pause there because I think we're out of time.
Yeah, that's great, Rob. Thank you. If you want to stop sharing, and then we'll get Keely to bring her slides up. So Keely Elwood's joining us from the Mayo Clinic. Thanks,
right.
Keely.
Perfect. All right, I think it's coming up there. So my name is Keely Elwood. I'm an occupational therapist and a certified hand therapist. And we'll go through some of the rehab principles after kind of the surgical interventions that are completed for radial head fractures. So I think key things that I look for when I sit down with any patient, I really appreciate to read the operative note, try to look at the radiographs if they're available. I guess my big piece of advice, if you're someone that like treats patients that you're sending elsewhere to private practice or external therapy, if you can have someone from your team, print that operative note, it can be really helpful because we can see exactly what was done, whether it's that bony fixation, the ligament stability, types of fracture, and also the soft tissue structures that were involved. And then also to just include any precautions, because we can see kind of a wide variety depending on the service, the surgeon. Therapy-wise, I'm always going to start that observation the minute the patient walks in the room. Are they having to use their arm to assist with like getting up, getting down for some mobility, just the demands that they have every single day? Are they somebody that is, using their arms, as a mom or as a laborer or someone that is working a very high demand job. Kind of all of those things in my mind are kind of, taking those key points into consideration. Their pain level too. I mean, that's always important to, I think, address, especially when we're starting mobility, to make sure that we're able to provide some comfort there so they're not guarding, and that they're able to kind of, I think, too, gaining some trust as you're working through the therapy process and asking them to kind of push the motion. And explaining, the anatomy. That's why having the surgical or the opnoid can be really helpful. The structures that are involved and why the things that we're asking of them are safe to do and things to avoid, providing some education on the anatomy. I like to tackle after pain, making sure we're looking at edema, looking at different ways we can help get that swelling out of there. That's just going to create more congestion as we're trying to move. Looking at sensation and taking note of that, any incisions that are present, any bruising, looking at skin integrity, hygiene. Sometimes I've had patients come, with their arm by their side because they've been worried about moving it and they haven't been able to wash under their arm. Also looking at how their proximal joints are moving, shoulder, and also their distal radius, radial ulnar joint, hand, thumb, how everything's moving down the chain. I love this chart because it helps me get a good idea of the functional demands while we're looking at range of motion. I think someone that's very apprehensive to move or do exercises, I like to try to give them a functional task as soon as it's safe to do so, to kind of work on those light ADL demands, whether it's like putting lotion on their leg, reaching up to fix their glasses, shaving, because often those things don't feel like exercise, but they're still a really great way to gain motion early on. And giving them really specific examples. I want someone to be able to fix their glasses or maybe feed themselves a bite of food, but I don't want them like pulling on a heavy door. And that can also sometimes, again, help with some of those guarding postures. General rehabilitation protocol, again, kind of trying to see patients early on if we can, getting them, in as soon as possible within that first week post-op to try to help manage some of that edema. Looking for edema control, thinking about if it's a compression sleeve, if that's too painful or the patient's not able to get that on and off themselves or they don't have help, looking at like a low press wrap or an ACE wrap to help with the swelling, or even a little bit of use of like kinesio tape and like a web pattern to help some of that lymphatic reuptake. Getting them in an orthosis for protection early on, whether that's a custom orthosis or using an off-the-shelf, like a hinged splint, and making sure that they're able to get in and out of that for checking skin integrity, hygiene, and just making sure that it's not causing any pressure areas or they're not having any issues with the incision. And then starting motion, really thinking about being very intentional with that motion, trying to make sure that, again, they're not guarding, deep breathing, going through slow and controlled repetitions, being mindful of any ligamentous involvement, but trying to kind of, if they're not able to get some of that motion sitting up, often I can have them like rest their arm on the table or in a reclined position, just seeing if we can kind of get some more motion through that. Looking at soft tissue structures early on too, with edema, if there is muscle tightness from that immobilization period, can we do some manual therapy and work out some of those soft tissues? Can we introduce, again, some modalities for pain, whether that's ice after exercises or a little bit of TENS, help kind of calm things down and distract to get them going. So I have a picture of a static progressive orthosis. At least for us, we don't always have those readily available. It takes quite a while, up to 3 to 4 weeks, to actually get those to patients, depending on where they live. So if that's something that's needed, if we want something that is kind of over the counter, I try to initiate that as early as possible. Otherwise, that is something that can be made with just like a posterior elbow, but kind of along that proximal forearm, leaving that pan very wide, fitting them with a kind of fitted volar wrist support, and then kind of bringing up neoprene straps to kind of help get that return of supination. starting with motion, we really want to focus, I think, too, on regaining that supination, getting that glide, getting that mobility as early as possible. And then working down as they're getting further post-op, 6 to 8 weeks, getting rid of the splint, kind of gradually starting some strengthening, kind of working on that grip strengthening and isometrics. Let's see here on the next slide. One of the things, we have a couple consultants that we work with that like to focus on kind of proximal strengthening. And I think that's important too if anyone's having to return to like overhead demand activities, whether they're like a CrossFit athlete, a throwing athlete, or someone that works construction that's like reaching overhead. I think it can be easily worked into therapy sessions early on, working on core, working on some scapulothoracic strengthening early on, and being able to like activate the rotator cuff early to help with that motion, to help with try to bring some of that swelling down, but then also working on kind of maintaining some of that endurance and strength while they're limited in that first kind of interim period where they're not able to lift or do strengthening exercises. Other things that I keep in mind, any nerve symptoms, if there is any irritation of the PIN, or even the ulnar nerve from maintaining their elbow in a bent position, just that safe kind of guarded position. Looking at any contracture development, loss of motion. Every time I'm seeing someone, I'm taking measures of pronation, supination, flexion, extension, and really being mindful. I want to make sure that we're making gains kind of every single therapy session that we're doing. I think that's really important. And then also making sure that they're able to do things at home. Are they able to shower, get dressed, maybe finding adaptive ways to clasp a bra, getting their pants pulled up and buttoned, like just making sure that they're able to meet those functional demands. I'm an OT first, and I think that is always something that I want to touch on and address, whether it's the evaluation or subsequent sessions for the people that I'm working with. Here I just have my references, and then I just have a kind of leaving it open. I think questions, Q&A is next.
Great. So thanks, Keely. You had mentioned it, and I sort of want to get your opinion and then get the opinion of Doctors Jupiter and Wysocki. And you mentioned patients coming either for a thermoplastic splint or a hinged elbow brace. And do you think that those are interchangeable, or are there some that you would use in some situations and some that you would use in others?
I think they can be interchangeable, especially if you don't have access to someone that can make like a posterior elbow splint like efficiently and in a fair amount of time. I mean, we have consultants that, well, sometimes they refer us for the custom splints. Other times they always get like the hinged off the shelf braces. So I think it's just really surgeon preference. I maybe find that when people have ligamentous injuries or complications or more instability, they might go into a little bit more of the rigid fixation, like a posterior elbow versus just a hinged elbow brace. But also too, if their arm doesn't fit. So sometimes we've had people that arms are too small, or it's rubbing, or it's sliding, or people that have very, very large arms and they just can't quite get those straps figured out. And so sometimes the customs can be made a little bit simpler. We can write numbers on the straps and directions that we want things to be into.
Rob, Jesse, when do you use a thermoplastic splint and when do you use a hinged elbow brace, or are they interchangeable?
I don't favor hardly ever a hinged elbow brace. The reasons are twofold. One is, if you ever look at an x-ray of the hinge, it's not even on the joint. And number two is, if you really, as Kelly just mentioned, fitting can be difficult, and you end up creating edema between the two limbs of the hinge, the straps proximally and distally. So I think it's not useful at all. If I'm concerned about instability that we're rehabbing, or patient anxiety, things like that, then a thermoplastic splint may be helpful. But it too by itself is probably not a high place in rehab.
Yeah,
Yeah.
patients come in and the hinge is almost never in the place that the hinge our elbow is. I sort of think of them like for a biceps or something that the patient just wants a little bit of support, but it's not an instability kind of pattern as you were saying.
Yeah, I would tend to agree. I really don't favor hinged elbow braces. Usually, when I have someone in an elbow splint, it's because more than anything, I'm wanting to restrict their activity a lot. Usually, whatever we fixed or repaired, I don't think is super fragile with elbow flexion extension. I mean, maybe a distal triceps repair is one of the few exceptions where they really need to be restricted or they can probably pull it apart. But even our biceps repairs, a lot of our fractures, we're as you know, Keely knows, we're really trying to more often than not, 90% of the time, do early range of motion. I think the splint is more just to protect them from overdoing it. And I feel like someone in a hinged elbow brace, for them, they're going to be tempted to overuse it because they can move it almost like normal in many cases. And really all it does theoretically is maybe restrict some varus valgus. And I don't necessarily believe how much it really does that, especially in bigger arms. And so much of elbow trauma happens in larger arms, I think, as a lot of us see. So I don't know how much the hinge brace really does. So I think I would rather them be resting it almost full time in a splint, except for when doing dedicated exercises, but on their own or with the OTs, and just have full control, hopefully. Because I think a lot of times the patient's tendency towards hyperactivity is our greatest threat.
Agreed. So there's a couple questions about the references, and for anyone that wants any of the references, Keely's and others will be available on the YouTube channel. All these talks will be available, and you can just sort of freeze on that slide for the references. And then one last question as we're wrapping up, Jesse and Rob, indomethacin, Indocin radiation for concerns for heterotopic ossification. Any specific patterns that you think about it, specific patients that you may think about it?
For me, Indocin doesn't really proven to be effective. And if you really want to use it, patients don't take it all the time. So I think it's overblown. And the non-steroidals, you worry about bone healing. Second is radiation in an acute injury is not really a good idea in general. If you're looking at fracture healing, particularly, if you're looking at soft tissues, you have to be careful about that too. So in general terms, only if you had a sideswipe injury that had surgery, didn't do well, you have to do surgery again through a lot of soft tissue, then maybe radiation, one dose. But otherwise, I wouldn't favor that at all, nor would our radiology people do.
Yeah, I kind of agree. I think probably the use of radiation has changed a lot, even in the last 20 to 25 years. Like when I was a resident at Rush and training with Mark, all of the elbow release patients got radiation in-house. They were admitted overnight, got XRT. We did some research looking at some outcomes after XRT. It didn't appear to have a substantial difference. And it is hard because those elbow release cases, the HO cases, each of them are so different than each other. You're comparing apples and oranges, which makes it hard. But the potential risk does seem high enough and the benefit nebulous enough that I would maybe only consider XRT if it was someone who had something like a brain injury, massive HO that I take down surgically. And the thought of ever having to go back there again is nauseating. And with a brain injury part, we know there's such a high risk there, like a head injury. I'd maybe consider it for that, but that would probably be the only one for XRT. I know some of my partners give Indocin for almost any elbow bony articular case that they do open. So olecranons, radial heads, terrible triad, even like biceps repairs, and haven't found big issues with healing. And I kind of believe them on that. But to me, the HO risk after most of those cases is very low. And I do worry a little bit about the bone healing part, so I don't use it. I just use Indocin after elbow releases. So if I'm doing either a post-traumatic or an osteoarthritic elbow osteocapsular debridement, I'll just give them Indocin. Like Jesse said, whether they take it or not, who knows? We give it with Pepsid. But in those cases, at least, I think it's very low risk to give it, even if maybe the reward is pretty low too.
And any role for dexamethasone?
Yes, for sure. That I use a lot of Decadron, and so many of the surgeries I do, and absolutely with those cases, yes. Almost any open elbow surgery, for
Wow.
some sort of bony ligamentous stuff, I'll use it. Not like an ulnar nerve transposition or like an olecranon bursectomy, but any sort of deep elbow surgery.
Great. So we are right on time. I want to thank our panel, Rob Wysocki, Keely Elwood, Jesse Jupiter. I want to thank our AO folks, Abby and Mackenzie, and thank our audience. I saw a lot of familiar names as I was looking through the participants. So thank you for joining us for the talk. Have a good night, everyone.
Thank you.